Good morning, everybody. My name is Axel Hoffmann. It's a pleasure for me to have the moderation this morning with two, I can say, outspoken experts on these global health issues. We have André and Marcel. We will start with a first presentation of André, around 20-25 minutes, and then Marcel will do a presentation in response to André's. It's also a pleasure to me to introduce André to you. Before having been a director for government and government relations at WHO, he has also one leg in the field. He worked for more than 14 years in Africa, and 11 of them he was a district medical officer in Burkina Faso. So we just spoke this morning. He was one of the rare experts at WHO, really with a vast field experience at that time. He will give the presentation on how to handle the evidence base to improve decision-making, and I'm sure that we get some insight in these decision-making processes and also perhaps some insight in the gaps between knowledge and practice. André, it's a pleasure.
Good morning. The decision-making process in public health has attracted much attention in recent years, and it still does. Public opinion reacts to new and perceived threats, such as emerging or re-emerging diseases, risk associated with bioterrorism, and the introduction of new technologies such as mobile devices, GMOs, and nanoparticles. The public reacts with a demand for protection against perceived risks, whether real or apparent. Hence the question raised at this session, how to handle scientific evidence to improve decision-making. Can rationality prevail over emotional responses? Can science build up a body of information that decision makers could mobilize for action? Remember, asbestos, mad cow disease, HIV-contaminated blood products, passive smoking. These are examples of public health problems for which the decision made, or the lack of decision, or the lack of a timely decision, became a subject for intense public debate. In most cases, the supporting scientific evidence was available. Choices were delayed or were faulty. The question, therefore, is, are there better rationales for making choices in public health? Can we conceive of a scientific approach to arrive at a reasoned decision? Common responses call upon two disciplines. Economic analysis and epidemiology. These disciplines are not interchangeable. Economic analysis is a tool for risk management. Epidemiology is a tool for risk assessment. And these are two completely different categories. Let's have a look quickly at the economic rationale. We can say that the share of health and social service sectors in public and private expenditure has increased to the point that most systems no longer seem to be affordable, whether in industrial or developing economies, doesn't matter. In most commodity markets, the supply of goods and services adjusts to the demand for such goods and services through the mechanism of prices. In health, the demand is limitless, and the supply is entirely determined by cost and prices. Health, therefore, is not a commodity. The demand for health has no elasticity, which means that the demand is not sensitive to price and cost. One may even conclude that there are no public health policies, that there are only budgetary policies. So attempts to use an economic rationale as the main argument are opposed by both health providers and health users. None of them can accept the imposition for financial reasons of any limitation to the degree of sophistication of the technology on one side or to the benefits they are expecting on the other side. Therefore, no consensus on health policies can be reached using cost-benefit or cost-effectiveness analysis. But the importance of the economic factor means increasing challenges to the rationale for making decisions that are based primarily on technical grounds. And this is a process, decision based on technical grounds. This is a process which is ingrained in a sector managed by strong technical and industrial constituencies, and which relies deeply on rooted levels of emotion, principles and values raised by life and death, issues that underlie the public opinion. So public opinion on health matters makes sectoral choices more than a policy issues. It makes them a political problem. Had an economic rationality prevailed, tobacco would have already been banned from the face of the earth. That's my view of the economic rationale. Now, epidemiology as a rationale. Epidemiology is perceived as an alternative tool because it is the discipline which expresses mathematically the nature of health phenomena in population groups. Epidemiology aims at describing health and disease phenomena, their determinants and changing patterns over time. Epidemiology is the instrument of choice to assess needs, to document changes, to demonstrate trends, to measure effectiveness of interventions, and to document returns to health. Epidemiological techniques translate into mathematical terms the wide range of observations, relationships, and interdependencies within health systems and between health and other sectors, such as financial measures, taxation, agricultural, industrial development, the environment, and more generally, with public policies. The role of epidemiology can be extended to the forecasting of outcomes based on the known relationship between factors. Epidemiology has demonstrated its ability to rank priorities and to select programs that would seem to optimize the response. Epidemiology is a firm basis to develop mathematical models. Therefore, epidemiology has developed as the ultimate justification for investing in the health sector, as the essential tool for policy setting in public health, and as a prerequisite to economic analysis. The problem and the limitation is that epidemiology measures everything which is measurable and only that. It eliminates from the scope of the research the qualitative aspects of the situation, which cannot be encompassed into a mathematical representation of reality. And yet, public health is about quality of life. Public health cannot be reduced to quantitative inputs, which are only a fraction of the information we need to formulate a decision. In addition, mathematical expression gives a false sense of neutrality, false sense of objectivity. Furthermore, the use of epidemiology as the tool for policy setting often distorts the basic rules of the discipline and goes beyond the limits of the discipline as a science. Just to assess together and rapidly this morning the role of epidemiology, I propose that we briefly review the problem of the validity of indicators, the problem of the validation of the underlying value judgments, the failure of the assessed needs to be a fair representation of the demand for health, and the gap between knowledge and practice. Let's have a look at the validation and the limits of indicators. Epidemiology uses mathematical tools, averages, percentages, ratios, and many more. The resulting figure for practical purposes is one single number, which we call the indicator, which expresses available information with a degree of precision and confidence limits dependent upon the accuracy of the measurement tools, which we call the parameters. To simplify the calculation, to facilitate comparisons, and to represent the situation in a nutshell, the tendency is to develop compound indicators that better represent complexity. Compound indicators are influenced by what is measurable, what is included and what is excluded, the degree of precision preserved for each measure, and the weight given to each measure in the compound indicators, and that's a key factor, the weight. We will get to this point further. But to begin with, in reality, the selection of an indicator always contains a value judgment, which is never spelled out, which may reduce the freedom of the decision maker and somehow preempts or rules over the decision itself. Moreover, if the underlying value judgment is not recognized and is not validated, the entire process is at risk of becoming, in essence, a pure manipulation. Let's take a very simple example to understand. Using mortality figures, it implies that the social and economic cost of disability in the community is disregarded. Is that consistent with the experience of that community? Can you compare communities using mortality figures? Does that make sense? Let's take another one. Measuring progress and comparing country status using life expectancy at birth is a common procedure in both economic and public health literature. The logical consequence is that the reduction of infant and child mortality is identified as the key to further progress, because infant mortality has the biggest weight in the construction of the indicator. So this popular indicator makes the implicit value judgment that infant death is more important to the society than adult death, and even adult health. Many decision makers are unconvinced that infant mortality is a priority, when adult health is too poor to assure life-sustaining production. This is open for discussion, but the assertion that when a mother dies in delivery, the death of the infant is more important to the society than the death of the mother contradicts common sense. However, it is nevertheless a direct implication of the selection of the indicator. You may use similar reasoning for all indicators we select in any epidemiological study. All of them have an underlying value judgment, which we have to make explicit if we don't want to manipulate the data and to manipulate the information. Schools of public health have developed sets of indicators to interpret conceptually the role of epidemiology for decision-making in public health. So you may be familiar with the iterative measurement loop developed by McMaster University in Canada, with the disability-adjusted life years, the DALYs, with the quality-adjusted years of life lost, the QALYs, and with the compounded performance indicator developed in 2000 by WHO to compare health systems. First, it can be observed that increases in complexity are associated with a reduced sensitivity and with a widening of confidence limits, making compound indicators not robust enough for decision-making. The successive multiplying factors introduced for the calculation of the final compound indicators multiply also the uncertainties of basic inputs and assumptions. And usually compound indicators are not robust enough for decision-making. Second, the process leading to the decision is biased. Epidemiologists are requested to assess the burden of a series of diseases in a population, whether directly or indirectly through the DALYs or the QALYs figure, Daly's and Qualley's figures are good indicators because they give a representation of health rather than disease. So I'm not sure that, by definition, they are a good tool to document the importance of diseases and the ranking of diseases. But then, using Daly's and Qualley's, whether they represent or not the disease, they are used to classify diseases by order of importance, depending on their respective impact in the population. And these targets mechanistically become priorities for action for the decision makers who seeks and is convinced that he or she has found objectivity. I maintain that this process is an abuse and a distortion of the scientific method. There is a double leap forward, which is not substantiated by science. The first one being the leap from the ranking of diseases to the setting of priorities for action. The second one is the leap from a list of technical priorities to proposals for resource allocation that are selective. The basic assessment is a scientific process. The further steps are not science-based. Epidemiology does not and cannot substantiate such moves. Let's have a look now at the representation of the demand for health of the population by epidemiology. The epidemiological method, also called needs assessment method, presumes that the population shares the same values as the observer. It disregards or discounts the context of the decision. I remember the preparation of a World Bank project in Mali a few years ago. Epidemiologists determined that the burden of disease was highest for malaria, diarrhea, and measles, which would therefore be priority targets for action and investment priorities for the World Bank. Social scientists, whom we commissioned, social scientists conducted field surveys. And these field surveys ranked fevers, that's malaria, hernia, which impairs the workforce in agriculture, and maternal death, together with debilitating complication of deliveries, as the major health concerns of the population. Who could challenge them? Epidemiology, in this particular case, did not provide a fair representation of the demand of the population. Public health specialists tend to develop normative approaches. Primacy of prevention, health for all, primary health care, Millennium Development Goals, universal health coverage, and so on, and so on, and so on. Whatever the soundness and the merits of these generic approaches, whatever their impact, they are not perceived by any population group as a response to their specific demand for health. Yet, no public health program succeeds if the target community does not develop a sense of ownership and of benefit. Communities cannot develop ownership of a program which fails to respond to their main concern. The perception of health needs by people differ, often strikingly from the assessment needs by epidemiologists. Epidemiologists emphasize the importance of determinants, leading to prevention rather than curative action. Communities use different value systems, which may place greater importance on individual conditions and on the living environment. Listen to the current debate taking place at present on what the societies in which we live perceive as the major public health questions of the day. What are they? I'll give you a short list. Which strategies to cope with prolonged human lifespan? Should life be prolonged at any cost? How will societies adjust to the perceived burden of an increasing proportion of older persons? Can individuals decide to terminate their own lives and the modalities to do so? Is euthanasia a modality? Can younger decision makers address and decide these issues? Another set of questions relate to the family as a social unit. Can parents decide upon the desirable size of their family? Should the society promote pro-natalist policies, or should the society authorize abortion? Can pregnancies by using surrogate mothers complement or substitute in vitro fertilization and the range of other treatments of infertility? And what about matters related to individual care? Which diseases should be treated at no cost to the patient? Which diseases can be left to individual initiatives? And which one should be taken care of by community through social security schemes or solidarity networks? Which diseases should be included in prenatal screening and destined for eradication through selective abortion? In almost all these cases, and this is just a list of the public health concerns in the society, in almost all cases, an ethical conflict arises between epidemiological methods and popular expectations. In most cases, scientists lack the relevant tools to address the issue, and science is of little help to articulate the response and to advise the decision maker. That brings me to the fourth issue, which is the gap between practice and knowledge. In the case of asbestos, in the case of tobacco, the case of problems such as the lead content of drinking water, scientific evidence had been available for over 50 years, and yet no action was taken. The same occurs with the persistent use of drugs for medical purpose with no documented health impact or no proven efficacy, and more recently this is the case in regard to the persistence of diesel fuel for internal combustion engines. Delays in the response to these known problems may result from the cost involved, from the influence of lobbies, from conflicting expertise, and from the difficulty of changing habits and behaviors. Science is plural. Every scientist, every expert supports a robust opinion on his subject matter, which is often a very small aspect of the overall picture. Few scientists, if any, have the global vision to offer a synthesis of the technical recommendations and assemble them into a coherent package of scientific advice to the decision maker. And it is left to the policymaker with short and technical knowledge, but exposed to an abundant amount of conflicting technical information and sometimes to powerful lobbying, it's left to him to achieve this. There is a gap between knowledge and practice, between scientific evidence and decision. And it should not be a surprise. Almost 100 years ago, in 1919, Max Weber developed the distinction between knowledge and action, developed the separation between the production of knowledge and the utilization of knowledge. And this was the subject of his two essays, published in 1919, Wissenschaft als Beruf und Politik als Beruf. Both remain relevant today. And if you're interested in the subject, I encourage you to reread Max Weber. Up to now, all decision models based on non-Marxist approaches have adopted Weber's distinction. It means that the sphere of intellectual production is completely independent from the sphere of activity. They never coincide. Politics is how best to optimize the necessary overlap of the two spheres in a democratic society. Mad cow disease and even the HIV-contaminated blood products issue exemplify another aspect of the situation. The call for public action most often comes at a time of scientific uncertainty, because expert technical views enter the public domain, especially when they are in conflict. Decision makers are under the pressure of public demand for protection from a threat to health through urgent action. And scientists have not built enough evidence to deliver unchallengeable advice, because the nature of science is that it should be challengeable. Decision makers are left in the most fragile situation when they have to respond to public anxiety because they will not find consensus easily because of the lack of firmness of confidence among the experts. The situation was described by someone you probably know very well, with Umberto Eco. And Eco was responding to a question, I think it was on the Italian TV, about the importance of intellectuals in politics. And Eco responded, and I quote his words, "Politics is the art of the possible, and a politician must inspire confidence. An intellectual must seek the impossible and must never be certain of what he wants. An intellectual who doesn't doubt is no longer an intellectual. This is why intellectuals are not designed for power and why they are potentially dangerous. And this is why universities were created to park them." Would you agree that Umberto Eco echoes Max Weber? It's the same approach. Public health specialists are definitely intellectuals. They belong to the sphere of the production of knowledge, which is enduring, questioning, and uncertainties. Given the situation, and for the sake of self-protection, and as a substitute for the lack of justification, politicians promoted the principle of precaution, which France even carved in stone of its constitution. Precaution is a risk management tool in the absence of risk assessment. Precaution calls for no action whenever the possible occurrence of a risk stemming from this action cannot be ruled out. Unfortunately, science has no conceptual instrument to define and thus to certify the absence of. It is, at the other end of the spectrum, a concept as theoretical as infinity. Zero as well as infinity are not scientific concepts. They are default options, they are philosophical concepts, they are a convenient proxy for ignorance. Science has little to say, therefore, to support or to challenge precaution. We don't have the tools. In conclusion, economists and epidemiologists have attempted for many years to develop objective methodologies from which could be derived the ultimate science-based and rational process for decision-making in public health. This rapid overview indicates that science at large, and epidemiology in particular, have failed to date and are likely to do so in the future. There is a discrepancy between the nature and purpose of epidemiology and the subjects of concern to the society. There is a discrepancy between public expectations and technical capacity. There is a discrepancy between quantitative assessments and algorithms and the qualitative essence of public health. There is neither a social nor an ethical validation of the measurement tools used by epidemiology. It is difficult to admit that sometimes science doesn't know, generating frustrated and insecure decision makers, whereas uncertainty is proper to science. Nonetheless, these difficulties, these weaknesses do not disqualify scientific research as a necessary input into the decision-making process in public health. They disqualify science to preempt the decision, or worse, to be used as an alibi for bad political decisions. They confirm that depending on the subject matter, the overlap between the production of knowledge and the utilization of knowledge, although variable, is nevertheless substantial. But faced with the enduring uncertainties in science, uncertainties that are essential for science to advance and its benefits to grow, there is no means, no mathematical formula even to decide how large this overlap should be. As long as there are uncertainties in science, there will be uncertainties in the good faith decisions that our societies make to preserve and to improve the health of our population. Thank you.
Thank you very much, André. And I would suggest that we continue with the second presentation, although if there is one or two questions for understanding, I would allow that. But otherwise, we continue. And it's a pleasure for me to introduce to you Marcel, who is the director of the Swiss Tropical and Public Health Institute and a full professor in medical parasitology and epidemiology at the University of Basel. He holds an MSc in medical sociology and an MPH, Master of Public Health, from the London School of Hygiene and Tropical Medicine. Although he's quite known as a researcher, he has also more than one leg, I would say, in the field. He can show a lot of long-lasting field work on different infectious diseases in Cameroon, Liberia, Tanzania, but also implementing programs, for instance, a primary healthcare program at district level in Africa, entailing all three major pillars: research, services, and training. So I would say his holistic expertise is not only shown in his more than 500 articles in peer-reviewed journals and in membership in dozens of associations worldwide, but also with a worldwide network of colleagues, partners, and former students. So we are very glad now to listen to you, Marcel. Thank you.
Thank you very much, Axel. Thank you very much, André, and thank you, of course, all very much that I have the pleasure to address a few words to you. I think was a very good entry point, and you know, Axel, what we have actually done is all what Luca cited from me earlier is just mutual learning for change. We try to learn together. And it's true that I will not go into defending science or defining science, and I'm very much in agreement that science cannot do everything, and it's only part of a process. And looking at what André will present to us in a first outline, I thought I would really enter in this topic, not just go one by one of his points, but rather actually going into this process of decision-making, what everybody calls in this sometimes sloppy way, evidence-based decision-making, and what it entails. So some of my worries are the same as André's worries, but I would like to really put it into this context, what it also means if you have not all possibilities to think that the academics have, but you actually are faced with situations of resources constraints, and you have to act and then make sometimes difficult decisions where you cannot satisfy all the expectations and demands. So the content is exactly that. André's stimuli, we take them up. And then actually I would like to go a little bit in this experience from national, subnational mainly decision-making process, because it is in this area, as you will see, where the biggest chance is that we can reconcile in the subnational level, reconcile a lot of the points that André has mentioned on reconciling needs and demand and having a creative listening to the needs of the population. And we will look at the different health systems. I would like to come back at the very, very end to our situation in this country. So I start always with this one, if I have to talk about that. You see, this is very important that you actually retain this picture, and it explains it all. And I would like to say that when we tackle the topic that André has now opened the box, the can of worms, as we would say, one would say, it's not only about tools and discipline, but it's much more about processes and strategies. Because you see, this guy here has certainly not the right tool to knock down this tree, but maybe has the right tool to protect the tree. And I think it is really that we take elements like, here is epidemiology, here is economics, here is a political process as within a process, within a strategy. That's step number one. So remember this. Second one, of course, it's very nice for us that we had the change today, that we were second and not first yesterday, because this was initially, because we can build on some of the points that were made yesterday. And as you remember in the plenary yesterday, it came the question, I mean, we know big data, thick data, thin data, whatever data. We actually wanted to know how can we reconcile these issues and what is the position in the process. And that is actually what André has also brought. So as you know, the data we have are not the data we want, the data we want are not the data we need, and the data we need are not available. That is the situation that we are actually in. And that's what also dear André was actually saying when we are sitting, for instance, at district level. In the same way, I was sitting at district level in Tanzania while he's sitting in Mali, and maybe it wasn't even at the same period, and we were struggling with all these issues. So the data question is, of course, this question here. Nowadays, it's just everything. The gigabytes are hidden in computers, but that is the reality we faced when we actually saw the situation. We had data that are collected but are not used, and so this was a very data-rich environment, but very information-poor environment. And it's still something which is very much underestimated in the discussion. People always talk data, 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 data. Data don't help you alone for a decision-making process, because that actually goes down the wrong track. And very interesting, in the year 2000, the World Health Organization presented a model. You know, when you have a few boxes and a few lines, it's called a model nowadays. And this was the model that was presented in 2000. And it's a little bit rearranged from the WHO publication because I want to make a point here. This was the model from the policy level, from the resource allocation to the implementation level. But as you realize, and that's why there is this hole in the middle, there is something lacking in the 2000 model. It's actually, where is the evidence? Where does the evidence influence? Go back to the old model of WHO's health system. It lacks this evidence, this health information, and this health research element. And you see already here, science, research is only part of the whole story in a big process. So now we are working with this actually model, in a way, the framework of this connected subsystems. And you can find it in this book, which I really recommend to have a look at, by Don De Savigny and Tagrid Adam in 2009, Health System Thinking. It's very good stimulus to understand health systems context, where these issues that André mentioned have a position. But of course, it's not enough just to do health system thinking. We must also, after having thought now since 2009 about it, we should do something sometimes in order to bring this moving that on. And I think this is something which I would like to bring in, which shows the perspective also that André wanted to bring in, maybe not in such a radical way, but it is it's in the process. You see the data, they start here. And actually then you have to compile and manage this data and analyze. Then you get information that's no longer data. And then actually comes your interpretation and the evaluation. And so it's no longer just the scientist and the statistician who is actually milling through some data until the computer vomits a p-value that is significant. This is actually this important process that leads to evidence. But there you are not yet, you cannot just throw around evidence and then you think that decision makers will understand that. It's the knowledge building which is important in this process. Actually, where you actually present the data, not manipulate. Present the data and digest the data, distill the data. You know, distillates are important. Not only for so that you actually have the knowledge distillate. And then you can start to bring it into a decision-making process, but not in the way where somebody says, I'm politician, I'm user, and I'm producer. It is actually the dialogue, the iterative process where stakeholders are part of these decisions. And then you may have impact or not. and you may actually change and then monitor, and then you will come back to your data. This is not just a theoretical cycle. I would all of you, us that are in different levels of generating information, generating data, and are actually involved in decision making, should really go back to that one. Not run to the minister when you have a little bit of data. Nothing changes then. It's this cycle that counts. That's the process. And at some steps, there are very clear elements of science, of qualitative and quantitative science, that have to come in order to come to impact. You know, we were in the year 93. This is, you don't have to read a lot of these world development reports. But there is one important world development report which actually goes back to the questions also of indicators. That was 1993. Investing in health. Many people remember this development report only as the report when the DALIs were introduced. And then they think, oh, so these figures, these DALIs, I don't understand what this is all about, and big row about if they are now culturally sensitive or not. But much more important than this introduction of DALIs, and we know they were further developed, further thinking about not only disease, but risk-based DALIs and things like that. The most important issue is actually that you have a paradigm change, that you say that you cannot just optimize good health, but you basically have to reduce burden. Because in all societies, also in this Swiss society, we don't have enough money to actually address all the health problems we have. So there are people also, the technocratic, I mean, this is now a dichotomy which is not wrong, no, it's just for a little bit being drastic. The technocratic view says you just rank morbidity and mortality, you see what you have as a technology, you choose and you apply and you do the job. That's very clearly the thing which André also said, it doesn't work. But all the other ones say, no technology. We go the software, you know, the software approach. It's all about management, it's all about logistics, it's all about training, and then we do a good job for health development. Also, you know very well, you need some technology with the best intention to have the software approach. So it's reconciling this, and reconciling is really the thinking which is in the World Development Report 93. We are 20 years into that one, but people mostly remember it for long lists of DALIs instead of a very conceptual change which says, look at burden. Most of the burden is in the most disadvantaged people, in the poor people. And the spectrum of burden is relatively small. You don't die of 2,000 different things in the majority, these poor people. It's a small spectrum of burden. And never forget, not always cry for innovations all the time. Of course, you should have innovation, but also there are many of the interventions that are already available. If this is true as a thinking, and you bring this together, and you apply it, tailored to a setting, you have the biggest impact on the overall burden. And, more importantly, if you apply this logic and not the logic of optimizing good health, then you have actually the biggest impact with regards to equity. And I think to actually have an equitable health system and an equitable allocation of your resources to a given health care setting. As you can comment, they say this again is academic thinking. No, you see, if you are confronted with translating this into a real-world situation, you just ask what are actually the needs in health planning. If you are not sitting in the university in front of your laptop, you say, what do I need? You need minimal essential information. That's where I would say the academics go very often totally wrong. It's because they always want maximally generate data. When we have to plan health systems, we need the minimal essential information which come from the users and providers. Most probably you try to get it participatory to address this question of needs and demand that come in time, not after somebody has done a thesis in 5 years and gives you the information. There must be adequate information. It doesn't have to be so precise, because it must be the magnitude capture, and therefore it must be applicable. That's actually what we ask from when we are on the health planning side. And I think this is where we have to reconcile what we bring in to the be it epidemiologists, or nowadays these monitoring and evaluation specialists. Many of you know that I have a total aversion against these hopeless hunter-gatherer operations in monitoring and evaluation that goes on in this world. We collect thousands of indicators of what very few are really relevant. It's the concept of not collecting what else you could collect, but it's thinking what is minimally essential in space and time that I can need to make a decision. And I think this is something which gives the negative image of sometimes epidemiology, and particularly these hopeless monitoring and evaluation specialists that roam the world. It's true, it's too much. The Global Fund is actually overdoing it in a very major way. Every day they create a new indicator instead of reducing the indicators in order that we are not overloading our staff in the districts with filling in endless spreadsheets. And the thing is what I said 2 years ago here, the way forward is to have a notion. That's now important as an answer to André, that you should always have your thing not in M&E. You should have your thinking as surveillance, response. When you're responsible in a health system, you must have eyes for surveillance so that you can respond, and not eyes for M&E. That's a direct point which actually validates these indicators that capture what is going on in our population. And there is something which also many people always look at the health information as health status information. But my dear friends, there are 3 other groups that are important, which we hardly examine in your country. If you come now from the Ukraine, from Switzerland, from Ghana, from Tanzania, from Malawi, from Mozambique, examine your health information system. It only contains mainly health status information. It's very little on health impact, it's very little on health service information, and it's very little on health behavior information, on risk behavior and so on. That's a comprehensive information that captures, and in André's point, it leads to the bad impression that it gives to the health information system people. If we would have a really information at these 4 levels, we would better address this issue in this process. And you have all this information and you have to set priorities, and there are only 5 points that are actually important for priorities. The magnitude, the impact, the vulnerability to management is if you have an intervention. You cannot start wild priority setting interventions when you don't know what to do and you have no means. The concern and demand and the cost. So basically, if you pull this down to the question of minimally essential information, when you look at the provider's side, on the need side, and that is what André also hinted at, how do you reconcile needs and demands? On the provider side, you want to know where are my health facilities, what is their structure and function, and what is the quality of care provided. That sounds a little bit provocative, but I don't need to know more. That's the key information I need from the provider side. And the key information I would need from the user side, where do people come from? What do they feel about what we offer, the perceived quality of care, not the technical quality offered? And how much do they invest to utilize your service? It's all the services, be it small, be it large. And the most important thing is, who are the non-users? If you're in charge of a health system, the most interesting question is, who are the non-users? Because the users come, and you can ask them all sorts of questions. You want to know why there are people here close that don't use my services, be it in private or public. Then you understand much more about the health systems than doing a 500-page questionnaire to users of health services. Now you can say this is all theoretical. It's very much privileged to be associated with the Tanzania Essential Health Intervention Program ages ago, exactly after the World Development Report 93. Here you see the 12 biggest priorities, burden. You just have to look at red and green. And each of this panel is one district. And what you see that red is the burden and green is the funds allocated, harmonized. So if the health planning would go well, the green and the red column would be the same height. Because you would, in this logic of reducing burden, use your scarce resources to really allocate it where it is most in need. You see? So this is in order to do this planning process is not just to send a few epidemiologists out. You need district health teams which represent also the community, where the social science part come in, where actually people have also the voice of the community. Here we have in this project gone at only 12 major things. One is other, so it's basically 11. And it starts with the IMCI, the care for children. It is the malaria side. It's the safe motherhood side. It's the STDs. That was still the old definition. It's now STI. That's why we changed the name at the institute, because we are no longer STI as before. It's not the only reason. But and then you come to TB. But you see some interesting thing. You have EPI. So in EPI, very often they think it's a need, but and they allocate the resources. So it's a heterogeneity. But after having introduced tools now, that's our tools, planning tools, having the process of district health teams, district health management teams, where you had also representatives of patients, civil society, you could actually achieve district health plans that were like that. Quite a harmonization where actually the main priorities were actually followed by the respective allocation of resources. And now it's true that I repeat now a thing that have many seen, but this was the success that actually helped to, in these two districts, that first of all you see $1 more per capita in this process led to a situation. I show you the data here from the childhood mortality. These districts were way up, and that is the trajectory they should go for to reach the Millennium Development Goal. So they were way up, and then something happened here. $1 more was introduced to get at this planning. Burden-based, allocation of resources, based on district health teams. And then you see it suddenly goes down, and now Tanzania has achieved the Millennium Development Goal number 4 already in 2010. Because, you know, initially when we showed these results, people said, yeah, that's easy. These are just 2 districts, 1 million people, but we are a country of 35 million, now nearly 40 million people. Show us that this works for the whole country. So the tools were introduced in the whole country, 130 districts, and led to these results. That actually the goals were achieved in 2010, 5 years before. Also, many people always say Africa is a lost continent. In a way, it's not a lost continent. I give you an outlook. It is this approach of having burden-based planning under resources constraint that reconciles needs and demand. And the important message is here, which also came out of André's point. The process of obtaining the information is sometimes more important than the information itself. Because that is when you work here at the level between the district health system and the civil society, that's actually where you do the plan. That's actually where you reconcile needs and demands. And this is not to make now a big, let's say, academic debate, but whenever you look at processes, how this went, it was surely the decentralization that mattered, that helped to bring in this type of planning approach. So this is the summary of what actually brought the success and shows you use DALIS. You don't say it's the overall guiding principle. You use DALIS. You actually do the packages by reducing the burden, as I tried to show you. And you have actually a best impact on those most at risk and the most vulnerable, the most marginalized people. And this is this, you respect the equity principle. Those in German, Verteilungsgerechtigkeit. And now it comes a big step. We come to the end. You know, this is something where the rich societies could learn a lot instead of just jumping into these discussions of rationing and rationalization of healthcare in wild discussion between politicians, scientists, ethicists, and so on. Take this concept and try to bring it to live it here. What some people call this reverse innovation. I don't think this is just sharing across systems and cultures. How can we learn? You know, I would think that we should stay the same. We have more resources in the north, but we claim we should rationing, and rationalization becomes an issue. And this was about 15 years ago, it was a big issue in Switzerland here. So I would actually propose that this cost effectiveness remains crucial, but actually it's actually the cost utility which is actually more important. DALI as an outcome and as a single outcome measure can help. And you rank basically intervention based on the cost utility analysis. And this is at this level you actually do the political discussion, the ethics discussion, the moral discussion, the societal involvement, and not the moral and ethicists at all levels, and not the scientists at all levels, but let us have a framework. And this is actually how it would look. You rank your interventions here, top, first, down by this cost utility approach. You then actually look at each one and you think, how can a single intervention, I can rationalize it still? And then you ask the question, how much am I ready to invest in my health system? That's the red bar. If you put the bar here, you can have actually less interventions that you can actually offer to the population. If your red bar goes down here, you can include more. And this discussion here of the positioning of this red bar would be the political, ethic, and moral discussion a society has to undertake in order to say, this is the package that we actually support. That's the package that we as a state, as a canton in our situation, can support. And this process would be, only by doing it once, would be very educative for our health ministers. We have 26 in our atomized health system in Switzerland with 26 health systems. But this would be a process by which you would respect the thinking of burden-based health planning and not optimizing good life. You have a scientific basis, but not the scientist that decides. And you have a societal discussion that actually meets this bar. And it would help to think about financing schemes. So what my message is, we should avoid, and I know that André was deliberately putting it a little bit like this, we should avoid false dichotomies. Epidemiology and economics, we need them both. Epidemiology and sociology, we need them both. The qualitative, quantitative, we need to combine. I would even say only quantitative epidemiology is a very bad epidemiology. And I think it should extend to concepts like cultural epidemiology. So the issue of qualitative and quantitative in epidemiology and public health should never an issue. It is always the mixed approach. We should not avoid just say here is needs and there is demand, not in the economic sense, but it is in the, but it's really we should reconcile that one. And when we talk about producers and utilization, Max Weber, it's truly interesting to read it, or Umberto Eco is a little bit more interesting to read. But I think it is this we should combine. It's not to see these dichotomies. And we need all these disciplines within processes and strategies, and I hope I could really give you an outlook on that in order to live this framework. That's just a repetition that you have as a pro-memoria where all these dichotomies. We should actually go from community effectiveness to equity effectiveness. That has been an old claim of mine, where we said that it's not only enough to look at effectiveness, but you should always use whom you cover with the effectiveness, be it now here the children from Switzerland or the children from Mali. André, it's from your Mali here, these children. And I think it's always the same thing, the deliverables in a health system versus actually the level on distribution in a given social political system. That's what we also with this process try to show. So that's the take-home message, equity effectiveness. And I thank you very much, and don't give up in this drive to that one. That's what our dear colleagues tell us. Thank you.
So, thank you very much, Marcel. Just before we open the floor, I wanted to ask André, is there a direct response to Marcel's no? So we can open the floor. Okay, yes. So please, yes, please. Is there a microphone for here?
Thank you very, very much for your speech, and especially for the last slide you are presenting there. So with all the organizations involved, it's really inspiring to hear you and your vision of how to proceed. Thank you.
Thank you for that.
You should never give up on these things, that's true. But I think it is what is inspiring for us. And you sit very close to Dr. David Evans from WHO, who has actually from the WHO seat accompanied and lost us in this thing. It is that despite all these claims that people say, we have the recipes, we know where to go, we actually had to find, just after this World Development Report in 93, a new way to practically show it. I was not wanting to be negative also on this issue on health system thinking, but it's not enough. We had already 3 years ago in the plenary lecture here, we talked health system thinking. But it's not enough to think, it's to act. And many of you are in a position where you can make a difference. And the problem nowadays is that many who have actually responsible positions, they don't want to act. They want rather to sit in panels and discuss and conceptually do things, but in order just to get the things going. And that there would be a lot of need in all your countries you represent, that people just are there in a humble way, just want to try to get the health planning, the priority setting on track. And I discussed last night with my colleagues from Mozambique, Malawi, and from Tanzania, and we said actually how you get stimulated, even as a scientist, when you have to handle the politicians. For instance, when we had to re-establish the urban health services of the big town of Dar es Salaam. It was a nuisance to have these politicians in these discussions. Mm-hmm. But it was actually the most stimulating way that you came to these results where we can show it as a positive outcome.
Okay. Thank you. So I have three now. First here, the lady, then Nino, and then here. Yes.
I think we all liked very much, Marcel Tanner, your speak. And it looks so simple, but what does it mean? Does it mean taking half the health budget of Switzerland from the already happy Swiss children and give it to Africa? Or what are the three, if we keep the budget in Switzerland, what are the three things that we focus on, and what do we stop doing?
Yeah.
Shall we first?
Yes, we collect. Yeah.
We collect some questions. Nino, please.
Well, thanks a lot for the stimulating inputs. I would like to continue the question, actually, Marcel, you asked yesterday, and it very much relates to your question. I mean, it's very nice to see what we should do, to go from the data to the evidence, knowledge, etc. What concretely, rather than move budgets, what concretely could we change in the Swiss system, as an example, to achieve that goal? Do we need different task forces where all these experts are in to take decisions together, or how can we move toward being less fractionated? Because of course, as you mentioned, all these boxes exist. We have the data, we have information, but we don't have them around the same table. So how could we really move forward?
Third one, and then Luca, and then I think we go to the panel.
Also, thank you for the two excellent speeches. I was inspired by this idea of the gap between knowledge and practice. And as I understood in the first talk, you said these are sort of two different spheres, and there is the gap. You know, one is the sphere with the doubts, and the other one the sphere without the doubts. Whereas in the second speech, I heard that the gap should be bridged. And my field of interest is health technology assessment, and that's particularly one field where you try to bridge the gap. You know, you start with a policy question, you do research, and you feed it back to the policy-making side. However, as I see it, you know, from a university or academic perspective, HTA is not seen as sort of proper science. There is no chair, as I know, at the university for health technology assessment, because it's probably too practical. So my question is, in what direction should science move? You know, should they be more driven by policy question and would corrupt that science, or should they just be more independent? So that would be my question. Should science produce results that are useful for policy, or should they not care about that?
Okay, thank you. And the last question in this round to Luca.
Yes, I would like to try to link the two speeches, because as far as I understood, André, your point was that indicators, numbers, at the end are disputable. No? I mean, at the end you have a number. And although you presented, Marcel, a broader picture, you know, how the process engage society, community, but maybe, Axel, you can go back to this the very crucial slide about rationing and rationalizing. And here, yes, the crucial element of this slide is this ranking of intervention by cost-utility analysis, because we are back to maybe to a number. And in particular, if you look at utility, we as economists know that this, no economist has seen utility function, although we speak a lot about that. So utility is something that you can influence if you, I don't know, assess utility through willingness to pay or contingent evaluation. So what you get out of this process is not at all a reliable measure, because there is lobbying going on in influencing utility measures. So my question is not to disputing, but how you can introduce in the discussion of this ranking all the process that you have shown us in the rest of the presentation, because I think this is a crucial point to highlight.
Okay, thank you. So perhaps the first two questions have the same target, looking what are the concrete steps we could think about here in Switzerland. Perhaps we tackle that first and then we go to the two other questions.
No, thank you. I think my point would also start here, what you should do. I think it is, and that's why I have to go back to Luca's point. I mean, this was all created, and the success in resource-constrained settings was by taking as the, let's say, the ranking always one variable, and not the disputing and influencing was always taking the DALIs, the cost per DALIs that you have worked. That was not used for life-saving operations and things like that, but for the planning and allocating of resources. So that's the way how this should come back. We would have to think maybe a little bit more on the cost utility measures that we use, but the important point is this one variable at the end. And then the ranking is really in this way. And the red bar is important, because that's actually the discussion by the civil society and what they would like to invest. And there comes another dimension, also the political dimension, the ethical dimension, and the moral dimension. So I would think, going back to Switzerland, that some of these approaches that we have learned in a situation where we have 20 to 30 Swiss francs per capita to invest in some African or Asian countries, that we actually would go to the Swiss situation where we have some 7,000 Swiss francs to invest, and would actually ask the question, if not at the cantonal level, the planning teams could just strictly pursue an approach by thinking, I want to reduce burden, I don't want to optimize good life. Already this change of thinking, that your paradigm for allocating resources and priorities is somehow you want to reduce burden, because you know even in our rich system we don't have enough means to really cover all of the things. That would be a step which I would like to see in canton. We have done this as a trial between the canton of Basel-Stadt and the canton of Zurich. And we learned there that this is basically possible. And we have published this deliberately in German so that actually those people should read it. Not in English and not in a very specific academic journal. Now, where then you come into conflict with one thing in Switzerland that we have, what should you do? It's too fragmented. I said atomized health system. I use it in my lectures as a wrong example of decentralization. Take our corner where we come from, northwestern part, Basel-Stadt, Basel-Land, Solothurn, Aargau. These are all tiny cantons. But actually we should think, as this was already put forward, in areas of services. The district concept should be areas of services. So northwestern part of Switzerland is one area of service and not Basel-Stadt and Basel-Land and all the bazaar. That's why you read us so often in the newspaper about health provision. And I think this is the second step you need to do, that we actually understand that if you have to provision services also on even our situation limited, because we must go to service areas and we cannot remain in this cantonal thinking. Here I may be too much primed by the situation in northwestern part of Switzerland. And I think these elements, the third point, what we should do, these should be prominent in the strategy 2020. That should be there. And in the strategy Health Switzerland 2020, this should be more prominent. That's what we actually voiced. And if we are getting at some of these elements, and that particularly at the planning level, Nino, we can also reconcile these data information loop. And there is a little bit of disciplines. First of all, I would knock down many committees and experts. That's right. I would eliminate many consultants. There are too many consultants because they get obscene honorary to be paid, and they are actually just telling always the same things. They have no innovation, you see. Very often. I'm a bit extreme now, but this should be a debate, you see. But I think it's reducing the pots, but having actually a better platform of exchange. And it's not just having everywhere an expert opinion and a consultancy firm that makes an assessment of the assessment for the assessment of the assessment. And there go hundreds of thousands of Swiss francs go into this nonsense. And one should actually have also leaders, not just, somebody who is in charge, a minister of health, should really take this seriously and also lead this. You cannot ask a district medical officer in the bush to do this, and here our people are actually must just make policy statements. You must sit down, because that's the core of your work, and do this planning process. That animates also the civil society and the scientists to participate. But if we have these things in Switzerland, then at the end you end up with a few scientists around the table, and then the minister wants a report. It's better he would invest one, instead of inaugurating a nonsense somewhere, he would invest in sitting 2 hours in a process and doing the planning, to understand how you dialogue between be it scientific people, between patient groups, as well as things. That's the thing, is an important thing. And I think this would be a very practical way that we had a change in Basel. And I happen to know also the new minister, and he said also the question that you asked me what to do. I said, you just devote more time to this actual planning process in our difficult situation than you just go to every evening to say, nice to meet you, opening, great, you do a wonderful job, and it needs people to do, and all this nonsense. This high-level, low-content things, you see. And I think this is where we must be more humble and we go down to work. The good examples, I really would like to say, and I'm very grateful that we have colleagues like Angelo Nyamtema here from Tanzania. Safi sana, Angelo, karibu sana. This is a person who has no time, except now if you come to his course, to sit down, and he plans his hospital, and he plans his district. And we are actually often taking this planning not serious. And that's actually where we start.
Okay. Good, thank you. André.
What bothers me, what bothers me a little in the questions raised and also in the discussions I had is that all the questions are, how can we influence the politicians? How can we better to convince them to do something? What I find enlightening in Weber's philosophical description is that the spheres of knowledge and the sphere of action are independent. If you use a Marxist approach, the spheres are totally confused because there is no independent production of knowledge. Production of knowledge is totally dependent upon politics, because politics is the ultimate expression of the wisdom of the society. What we are trying to do when we say, how can we best influence the politician? We are trying to do the reverse. We are trying to invade the sphere of action. And my point is that we must respect the politicians. We must respect the way they operate. They are dedicated people. Most of them are giving their life, most of them are spending their life for the good of the society. We should respect the way they operate. And if we try to invade the sphere of action, we do exactly the same imperialist process as the communists did the other way around when there was no independence in the acquisition of knowledge. And all the democratic debate in our society is, what is the overlap? How large is the overlap? How far do the politicians use the production of knowledge? How far the scientists should try to influence the politicians? This is the democratic debate, and we should not go beyond the limits of this democratic debate.
Thank you.
But just maybe to add on this gap, I think I would agree on that. That's what I meant to say. I mean, but you also must find a place where you meet the politician. And that's why that was my platform comment. So this complements the whole thing. And I think this is something where we could be more serious. But the other point on the health technology assessment and the gap, you should not now get nervous about if this is science or not. The University of Basel, for instance, has just agreed in a competence center on health technology assessment. And I think this it's very clearly recognized as an important point to bridge the gap. Mm-hmm. And I mean, you're most welcome also, you sit in Winterthur to collaborate with us on this, because that is where these efforts are needed. And you're right, you should not change and think something differently. But it comes now that we see this as a bridging the gap exercise.
Mm-hmm. Good. Thank you. So there's still a few minutes left for another 1-2 questions. Yes, please.
As economist, I totally agree with the restriction. But as far as I can see, in Switzerland, there's no acceptance of any restrictions from the citizens. And the politicians are looking for the votes, so they are not keen to tell there is any restriction. So that's the problem I see so far in Switzerland.
Mm-hmm.
No, you're right, that's basically okay, but I think when you start to go deeper, when you had this issue 15 years ago or 14 years ago on rationing and rationalization because of a famous federal councillor who should not get the treatment in Basel for an expensive treatment. I think that was actually where the discussion came up, and that's why we also did some work on this. But this discussion started to sleep again. It's maybe also on our side that we didn't bring it up. But what my experience at that time was, also in public events, that the population is not totally unlimited in a way, that they want to have it. It's true that we were successful in resource constraint setting because this process worked because people didn't have that. And you could actually make a priority setting and resources allocation. But if you come into a society where people have already everything, and they think they have even more than they have, then of course this process would involve that particularly these stakeholders and civil society process and these platforms are actually more than just a political movement, but they are really becoming a serious way. I mean, the basis we have in Switzerland with our commune system in order to really change a little bit the situation. And I could imagine if you would really go in service areas and not in the small cantons, where, of course, then across the cantons, and this again my bias from the northwestern part, where this is extreme on this expectation and what should be done. But if we have good service areas and we have to serve the northwestern part, maybe there is a way forward. It's not an easy, I don't say, but I would not give up. So look at this picture here. Don't give up. We were maybe responsible, exactly this community, that this discussion started to go into hibernation again.
Okay. One last question. Yes. Yes. Okay.
Yes. No, I had the opportunity to sit in the again in an expert committee advising the strategy Health 2020, and it was a discussion about overuse and misuse in Switzerland. And I think the point is that you don't need to use the financial argument to reduce overuse and misuse, because there is a health problem that you can produce by over-consuming, I don't know, MRI, computer scanner. I mean, this is the baseline that where you start. No? To say if we consume too much or too many health interventions, this can damage your health, has adverse reactions. I think this is a rationale that the population can understand, even in Switzerland, very easily. I think in many other countries where healthcare is driven by market forces, of course, without prices, and then you can come in a situation of overuse which reduce your health, your final health.
No, I think it's very good that you mentioned that's not only the finance driven. And I think what you do here, this mutual learning for change, should also happen now with this strategy 2020, when you ask for Switzerland again. When we had the first round tables, you know, there were many round tables. There were about 400 people or so in Bern. They were allocated to tables, and you had the different groups. So you were academics, civil society, patients groups, pressure groups, and whatever, you name it. So many we have in Switzerland. It was filling the Kursaal in Bern, the main big thing. And my observation, I came home very frustrated, because people did not take this opportunity of having such roundtables and platforms to really do what you do here now after the coffee break, mutual learning for change. But they were actually here just to defend their position. So a patient group would not listen to, let's say, a public health person, because we have to look for other things. And the academics have said, no, we did, and we generated the evidence. And so you were sitting a whole morning in Bern, and you actually did not see that even it's created around the round table, that people really wanted to learn from each other. I think this is what you should really exploit aggressively in these courses here, this wanting to learn from the others. Not so much only from the facilitator, because that's where we can create the atmosphere that we can better discuss that. And that's what I would hope also for this process 2020.
Thank you very much. I think that was a very nice conclusion. I want to thank, on behalf of the audience, to both of the presenters this morning. And lastly, I want to remind you that on your desks is the program and the schedule for the plenary sessions for the other days. And really, it's my wish that you come here in Swiss time punctually, so that there is no delay. Thank you very much, and have a good time today.
Thank you.